epilepsy affects 0.5% of the global population. 51 million people are impacted. That delays in diagnosis can average up to 3 years and beyond. Dr. Andrew Wilner, who is a board-certified internist, neurologist, and an epilepsy specialist.
There's an abnormality in the brain that can have many different causes. Seizures may also take other forms, just a simple staring spell or a confusional state. And I would say great news for people with seizure disorder. When I trained in the 80s, we had 6 drugs, and now we have 20 plus. 1% of the time, it's because that child is having a absent seizure. You should not hesitate to call 911. It's very difficult for the brain to heal from injuries. So a locum tenens physician is someone who holds the place for another doctor. As a locum tenens physician, you look for opportunities all over the country. Anyone who's interested, I would encourage you to read the book.
Welcome to KhanKlinics, your dedicated space for exploring the vital connections that shape your well-being. Here we dive into everything from achieving peak physical fitness by mastering sustainable weight management to optimizing your diet for a vibrant life. We're passionate about uncovering the power interplay between your mental and physical health, offering you insightful strategies to nurture both. Join us as we unlock the secrets to embark on your self-confidence and your inspiration by interviewing the top-rated personalities, not from only the US, but around the world. At KhanKlinics, our commitment is to bring you evidence-based information that inspires you confidently control your health journey and live your life to the absolute fullness. I'm your host, Amir Khan. Let's get ready to unlock the true potential of being a human with the most amazing people around us. Imagine you're comfortably, perhaps chatting with friends and in a cozy environment. And then, without warning, someone you know begins to shake violently. Their body stiffens, their eyes roll back, their mouth may start drooling, and they're not able to communicate with you. Wave of panic washes over the room. What do you do? What was that? What happened? What should I do? Then suddenly, terrifying events could have been epilepsy, a condition affecting millions worldwide, yet often misunderstood and often feared. And did you know that epilepsy affects 0.5% of the global population? 51 million people are impacted. In 2022, epilepsy was identified by the 75th World Health Assembly and the WHO as one of the top priorities in the prevention and control of non-communicable diseases. Another study found that delays in diagnosis can average up to 3 years and beyond. At the same time, locums is utilized by neurosurgeons across multiple practice types and may serve to complement workloads or fill in gaps between longer-term employments. WHO emphasized that task shifting and temporary staffing models like Locum Tenens are necessary, but must be prepared with enhanced clinical governance and standardization as well. Welcome to another illuminating episode of KhanKlinics. I'm your host, Dr. Amir Khan, and today we are joined by a remarkable guest whose expertise expands in medicine, media, and meaningful insight. I have Dr. Andrew Wilner, who is a board-certified internist, neurologist, and an epilepsy specialist with over 4 decades of experience in medicine and communication. He currently serves as the Associate Professor of Neurology at the University of Tennessee Health Science, Memphis, Tennessee. There, he balances a full life caring for patients, teaching neurology, conducting research, and mentoring the next generation of medical professionals. He graduated from Yale University with a bachelor's in biology and attended medical school life in France for 2 years. He completed another 2 years at the Warren Alpert School of Medicine of Brown University. That was in 1981. Dr. Wilner is also one of the nation's leading voices on locum tenens medicine, a path he discovered in 1982. And that was to better balance life with his work as a physician and a writer. Dr. Wilner, his best-selling book, The Locum Life, A Physician Guide to Locum Tenens, has become one of the go-to resources for physicians, exploring flexible, fulfilling medical careers. He's written multiple academic books, Bullets and Brains, Epilepsy, and numerous other books over the last 20 years. He also appeared in Kevin MD, Doximity, Medical Economics, and many other reviews. He's an experienced broadcaster and the voice behind Reach MD podcast, Neuro Frontiers. Dr. Wilner, welcome to the show.
Well, thank you, Dr. Khan, and thanks for that very comprehensive and warm introduction.
Indeed it is. We're looking forward then. So let's start off with a bit of an overview about epilepsy. We're looking for some common misconceptions, a disease that is really still underdiagnosed, yet has devastating consequences. Please give us a little overview about it.
Well, when I was a neurology resident back in the 80s, I trained in Montreal at the Montreal Neurologic Institute. And in those days, we had Alzheimer's disease and multiple sclerosis and Parkinson's disease, and we didn't have much in the way of treatment. But epilepsy, the Montreal Neurologic Institute was a world referral center. And I discovered that, this is something we can help people, because in epilepsy, there's an abnormality in the brain that can have many, many different causes. And that's one of the reasons why the diagnosis can be difficult. Epilepsy can be caused by a brain tumor, by a head injury, by infection. You can be born with it. There's a lot of different possible causes. But as you described earlier, sometimes the actual seizure or a convulsion, it doesn't really tell you what caused it. It's just that's what we see. And it can be quite frightening. And the seizures may also take other forms, just a simple staring spell or a confusional state. And because it can be so different and so varied, some people will have seizures 2 or 3 times a day. Other people maybe once every 2 or 3 years. And so the diagnosis is very, very challenging. And then the treatment will depend, of course, on what's causing it. Is it infection, a brain tumor, a head injury? Is it genetic? And what age is the patient? That's going to guide our treatment. Will medications work? And I would say great news for people with seizure disorder. I tell my patients, it's terrible that you have epilepsy, but the good news is you have it today in 2025, because when I trained in the 80s, we had 6 drugs, and now we have 20 plus. So we have a lot more options. We also have much more sophisticated surgical procedures and neuromodulation procedures, other ways of dealing with epilepsy, because each seizure is an abnormal discharge of neurons, electrical abnormality in the brain. We're familiar, for example, with heart arrhythmias. People can have irregular heartbeats, ventricular tachycardia, ventricular fibrillation. They might need a shock. Well, the brain also has electrical currents, and most of the time they behave. But when people have epilepsy, there's an abnormal electrical discharge, and the brain ceases to function for that time.
Excellent. Thank you for explaining that. Epilepsy in adults, epilepsy in children. How would you place both of them being relevant to our audience? Children also go very undiagnosed. What advice would you give to moms, parents in general, about, hey, what are the signs they should be looking out for? Your kid may have, or a family member may have epilepsy.
Well, when adults or children have convulsions or what we call generalized tonic-clonic seizures, that's usually pretty obvious. It's scary. Person falls, foams at the mouth, might bite their tongue, lose control of their urine. It's a pretty dramatic event, and you should not hesitate to call 911 and get it looked after until it's sorted out. In children, there can also be more subtle seizures, just staring spells, for example. And every now and then there's a child who's inattentive in class. And the teacher will say, I don't know, he just missed, just not paying attention. And 99% of the time, it's because the child isn't paying attention. But 1% of the time, it's because that child is having a absence seizure. And so sometimes we will do our best tool for seizures is the electroencephalogram. I mentioned the heart earlier. Everybody's familiar with an EKG. We put electrodes on the chest, monitor the electrical output from the heart. We can do the same thing with the brain. We put electrodes on top of the head, and we can see what the brain waves are doing. And so we'll often refer a child like that where there's a question. Maybe there's epilepsy in the family. Maybe there's some reason to suspect that these episodes of inattentiveness are really seizures. And then, of course, when children have other disabilities, if they have developmental delay, even autism, epilepsy is more common in those children. And so I would have a heightened awareness to look for these episodes of inattentiveness or temporary confusion, and then bring your child to the doctor and talk about it and see if any testing is necessary.
So you're saying, Dr. Wilner, if a child is not fully attentive, besides, yes, they could not be really attentive and be distracted, you should, or one should consider seizures happening to the patient or your child, and then you should seek medical help and explore that option further, but especially if it's on a persistent basis.
Yes, although I would, I don't want pediatric neurologists to be overwhelmed. Most inattentive children are just not paying attention,
Sure.
but a few of them may have, as you stated earlier, epilepsy is 1 person in 200, 0.5%. So it's not, we don't see it every day. It's not that common. On the other hand, it's at 50 million people in the world. It's not rare. So it's just something to keep in mind, particularly, because it is something we can treat in many, many cases very effectively.
Your book, Bullets and Brains, explores some of the long-term effects of gunshot wounds to the brain. Tell us a little bit about that, what your experience, what you teach, and how is there a connection in general?
Right. So Bullets and Brains, that title comes from an episode in 2011 where Congresswoman Gabrielle Giffords of Arizona was giving a talk. She wanted to meet her constituents, and she was shot in the head by an assailant who also killed several and wounded several other people at the same time. So the Congresswoman was medevaced right away to the hospital. And in the news, there was a big article about how the best brain surgeons in the United States were flown to operate on her, right away and treat her, and which was great. But I think what I didn't see, at the time I was working full time as a medical journalist, and what I didn't see in the headlines was sort of the underlying story that it's very, very difficult for the brain to heal from injuries, especially a gunshot wound, because bullets may be very, very tiny, but they come and they enter the skull, they break the skull, they go through the brain, and there's a wave of damage. It's not just the damage caused by that little bullet. It comes with a lot of force, and that force spreads like you throw a stone in the pond. You see those ripples? Well, those ripples go through the brain. And I think what people didn't realize is what a devastating injury this is and how little we can do about it. Yes, the neurosurgeons are there and they're going to stop the bleeding and pick out pieces of bone. And we would give the patient antibiotics so she doesn't get a brain infection. But that's what we did, except for the antibiotics, 200 years ago in the Civil War. we don't have anything that helps the brain heal. And you'll see patients go to physical therapy for months and months and months to try and get the remaining brain to work as well as possible. And in Gabrielle Giffords' case, when that happened, I predicted that she would lose her job as Congresswoman, which is what happened. A year later, she resigned. She had trouble talking. She had paralysis of her right side from the damage. I also predicted that she would get divorced because she was an incredibly high functioning person, very smart, very driven. And she's also married to a very high function to Mark Kelly, who's currently senator of Arizona and previously was a commander of the space shuttle, was an astronaut. This guy is not a slacker, but they actually were able to, I would say, work with this in their marriage, and they have had a successful marriage, but that's often not the case. So I wanted to emphasize that the brain, when you go to the operating room and you do brain surgery, you open up the skull and the brain is sitting there. You could touch it with your finger and it's soft. It's like jello. It's defenseless. You could just take your finger and poke right through it and damage it. And of course, neurosurgeons train for, 5 to 10 years so that they don't damage it when they're in there trying to fix things. But we need to really respect the brain was the purpose of my article. And also, I'd say that firearms should be used appropriately and by people who are trained to use them. That's certainly the other message I would like to share.
Well, thank you for sharing that. That's very interesting. I want to point out another question that's come in, and that's from a incident in October 2012. Another girl who was 15 at the time, and her name was Malala Yousafzai. Headlines at that time where a girl was shot by Taliban, and she was 15 at the time and going to school. And then, hold behold, she was also rushed over a plane to a bigger center and then ultimately to United Kingdom. Malala, pardon me, has since then completed her education. She's, I think, studied in England, finished her education, and is now very entrepreneurial, involved in providing education to girls in remote areas. So she's done pretty well. And I just want to re-emphasize, compared to Miss Giffords' case, Malala has done really well growing up. And it could be that Miss Gifford was an adult, Malala was 15 at the time. Just a sharp contrast between the two stories a little bit.
Yes, well, Miss Giffords has, she does speak now. She has recovered. She has a organization with her husband for gun control. She is functional, but she's limited in what she can do. And you're absolutely right. The younger you are when you have a brain injury, the better your options for recovery. And frankly, at my institution where I work at a inner city hospital. We see gunshot wounds to the brain almost every day. And we do everything that we can. And many of the patients, with all the treatment, the supportive care that we just described in terms of neurosurgery and then physical therapy, after time, sometimes we'll be able to return, if not to their former selves, but to a functional level. You can imagine what that girl could have accomplished had she not been shot in the head, right? This was an exceptional 15-year-old. And she did make wonderful achievements. But imagine if she didn't have to deal with part of her brain being damaged, what she could have achieved. So she has also a lot of brain reserve, right?
She absolutely did amazing. And I just want to reiterate, 2017, the incident happened 2012. 2017, she was studying philosophy, politics, economics. She was studying all of this at the University of Oxford. She graduated in 2020 with honors. And 2021, she got married and started a new life. And 2024, 25, she started her own Malala Fund and currently is a big advocate for supporting girls' education and providing 120 million girls access to school and providing an environment. So it seems like she's done really well. And probably for the right or the wrong reasons, that incident actually blew her up a little bit and made her prominent worldwide. And she also won the Nobel Prize and all that. So excellent. So and thank you for clarifying that. I mean, I think our viewers will love to know. Yes, you can have a injury. It may, in some cases, be detrimental. In others, you can still overcome and pursue a normal life. In fact, it could be a fantastic, inspirational life as well. We're going to go on to the next question, and that is about lifestyle and genetics affecting the onset of epilepsy. Please share your thoughts on this, and also please touch on laser ablation treatment. How does that affect epilepsy treatment and the outcomes?
We talked earlier about some of the causes of seizures, and head trauma is one of them. But in many cases, about half, if I see a patient in my office, had a seizure, we're trying to figure out why, we'll do an MRI of the brain, it's normal, we'll do an EEG, it's normal, and yet they have a seizure disorder. So the abnormality is something that we cannot see. So we presume it's at the level of the cell, that it has to do with an imbalance of excitatory and inhibitory neurotransmitters. And we believe in most cases that this has to do with genetics. Now, there are a few types of epilepsy that are inherited, but very, very few. In other words, you can identify a parent and a grandparent in a very autosomal recessive or dominant fashion. But in most cases, we cannot identify a single gene, but rather there's a cousin somewhere with epilepsy, there's another family member somewhere, that we think it's a whole bunch of genes that have to line up in just the right way, and perhaps with environmental influences also, to cause epilepsy in that particular person. Now, in terms of treatment, our first line is medications. These are pills that you might take once, twice, 3 times a day, and there's a whole assortment of them for different types of seizures and different types of epilepsy. If the pills don't work, we look towards surgery. In other words, is there a small area of the brain that's damaged that we could remove that is not going to affect that person's functioning? And the reason that you can often get away, you say, well, gee, I don't want to lose a piece of my brain, is that piece of the brain is actually damaged. So it's not working very well to begin with. It's causing the seizure. So if you remove it, you may remove the cause of the seizures without causing any additional dysfunction to the brain. So traditionally, that surgery would require a craniotomy, where you just remove a large part of the skull and burrow down in there and find the piece that isn't working and scoop it out. Well, it's a big job. So the concept came up, is there a way to, what's very trendy now in all kinds of surgery, and for good reason, is what we call minimally invasive surgery. Give you an easy to understand example is when I was in medical school, if you had to have your gallbladder out, your gallbladder is about this big and it hangs next to your liver, they would do a big incision, 3-4 inches, in your abdomen, open it up with their hands, reach in there and clip out the gallbladder. Well, now they use something called the laparoscope, where they make a few little holes and they put in to blow some air up there. And they got a little gadget with a light on the end, fiber optics, and some little tiny scissors, and go in there and snip it out and take it out. And 1 or 2 stitches in these holes, and you're done. You go home in a day or 2 instead of a week or 10 days later. So that's minimally invasive surgery. Well, somebody had the idea, what if we take a laser and we're going to drill a tiny, tiny hole in the skull rather than take a big chunk off. And we're going to use, technology. With MRI now, we can do 3D localization. So you can pinpoint something in a sphere with MRI, even in the operating room, and then aim that electrode, put it right at that spot, and then turn the laser on, heat up that area, and destroy it. And then remove it, 1 or 2 stitches, and you're done. So that's laser ablation therapy. And if not all types of abnormalities lend themselves, maybe it's too big, the laser isn't going to be able to remove a big piece if that's what you need to do. But a tiny little piece that's misbehaving, that's causing abnormal electrical discharges, you can use the laser to destroy it.
And the outcomes of the laser are as good as surgery, um,
Well, there's a
similar-ish,
rule in
worse.
surgery that the more you take out, the better your outcome in terms of controlling the seizures. And that rule's been around since I was in training. But, the downside of that is the more you take out, the more you may affect emotional or cognitive abilities. So you're trying to balance. I want to take out as much as possible, but I want to cause as little problem as possible. And so the laser errs on the side of taking a little. So I think the results are probably just as good, or if they're not, just a few percentage points below the traditional surgery. But in order to really know, you have to do very extended studies, 5 years, 10 years out. And I don't think we really have that data. But, if it was me and I had the choice, I'd probably say, you know what? Let's start with a laser, see how it goes.
Yeah.
If it doesn't work,
Yeah.
we can always do it the old-fashioned way later. But let's start with the minimally invasive option.
Thank you for explaining that, Dr. Milner. Dr. Wilner, we're going to shift gears and discuss something that we're very passionate about. And that's sort of something that you pursued for a long part of your career, and that's about locum tenens. Explain to our audience what that is, what inspired you to back it, and how do you think personally yourself and the people that you've inspired to do has made a change, positive or negative?
Well, it's kind of an interesting story. First of all, locum tenens, it's a very fancy name. It comes from the Latin. Locums is like locale or location, it's a place. And tenens is like tenacity, of holding on. So a locum tenens physician is someone who holds the place for another doctor. So it's a temporary job. I use the example of a substitute teacher. When I was in grade school, I remember all of a sudden, Mrs. Burke wasn't there that week. She was out sick, or she was having a baby, or something happened, and there'd be a new teacher for a week or two, and then Mrs. Burke would come back. Well, that substitute teacher was effectively a locum tenens person. And in the medical world, there's always been such a thing. Traveling nurses, for example, even back to the days of Hippocrates, he used to wander around, go from place to place, and fill in, where needed. It's different because most physician traditional jobs are either self-employed or employed, with a very strict schedule, right? These are the days you're going to work. You've got 2 weeks of vacation coming up 6 months from now, but otherwise you're there, from 7 to 7 every day. And that's the way it's laid out. With locum tenens, you, as a locum tenens physician, you look for opportunities all over the country and in many other places in the world, New Zealand, Australia, Virgin Islands, wherever you want to go. And you set that up and say, okay, from September 1 to January 1, I'm going to work in Minneapolis, Minnesota at this hospital because you guys have a need. So then you have to get credentialed at that hospital. You have to make sure you have a license in Minnesota. And then you just show up the day before and somebody gives you some orientation and you go to clinic or a hospital service. I've done both. And you just, you know what to do. You're a doctor and you practice medicine until 4 months go by. And then you go back home and you're done. There is no other commitment. Now, the other side of that is you don't get vacation pay. You don't get disability pay. You don't get any money in your 401k. No one pays your health insurance. You're a temporary employee. The upside of that, and this is when I started doing it back in 1982, is I wanted to write a book. I've known I wanted to be a writer since I was 12 or 13. And writing takes a lot of time to do it properly, at least in my case. And it's very incompatible with a full-time medical schedule, which also takes a lot of time. I'm only one person. So I struggled to balance these things. And during my medical internship, I knew it was going to be very demanding. I worked 7 days a week. So I said to myself, I'm not going to write. It's too hard. I'm just going to be miserable because I won't be able to accomplish it. So I'm going to do my medical internship, do 100%, hopefully do well. And then the following year, I'm going to work locums and I'm going to write my book. So that's what I did. And then I discovered that really worked well for me, that I love to put 100% of my energies into whatever I'm doing, to be 100% focused. That works for me. But you can see the light at the tunnel. It's like, okay, I'm doing this for 4 months or 6 months, then I'm done. Then it's my time. Then I'll come back. And later in life, I did that for about 10 years and spent a lot of time in Southeast Asia when I wasn't working locums, scuba diving and writing books and writing articles like the one we talked about Gabriel Giffords. That was published on Medscape. So I had my own time. And then, when I ran out of money, I would go back and I would work locums again. And it's also very interesting, locums, because you're going to a new place, new people. There's challenges there, but it's exciting. And I would say without exception, because I've talked to many other locums physicians, you're welcomed because that institution or clinic is recruiting you because they're short. Somebody left, somebody died, somebody's out on leave. They need you. And so when you show up, and the burden of you not being there is usually on the people who are there. So when you show up, you're going to pick up some of the burden that people who are already busy are having to, take care of George's patients and answer their calls and work them into their schedule. But now Dr. Wilner's there. He'll see all of George's patients and it's better for them. So everybody is happy. You have to be flexible because every institution doesn't follow the same protocols. And I know what I think is the best protocol when I see a patient, but it might be different in Minnesota. So they're probably not going to change their protocols because I want them to. So the best to smooth things out, you have to be a flexible person, kind of go with the flow when you show up. Don't try and change too much. Do what you're supposed to do. See your patients. But over the years, I have found it to be very, very helpful in letting me accomplish my other goals, like writing, for example, and publishing and travel, without being, a lot of physicians kind of feel locked in. They're working very, very hard. They're early, stay late. It's administrative stuff. And they don't really get to see what's beyond that because they've got their nose to the grindstone. And medicine is hard. To do medicine properly, it's hard. It's not a 9-to-5 job. You have to go home and read. You have to look things up. You have to think about your patients. It's hard. So locums is kind of a different way to do that.
Excellent. Thank you for explaining that, Dr. Wilner. So how do you see locum tenens evolving, considering the current landscape in America especially? And what advice would you give to junior physicians or residents who want to take this on as a sort of like little career strategy?
Well, that's the interesting part. When I started doing this in 1982, it was very personal. It was just a way for me to accomplish my personal goals. And it didn't really have anything to do with the medical industrial complex. When I wrote the book a number of years ago, it's my fourth book, and I was trying to think of something that I knew something about, because it helps as an author if you're informed. And I realized I had a very extensive experience in this locum tenens world that a lot of other doctors didn't have. So I put the book together. Well, that was sort of when burnout became a thing. And all of a sudden, we realized that many, many physicians are not happy with their traditional employment. It's also when employment of physicians all of a sudden became the norm. Because when I trained, when I was growing up, the model was you would graduate, maybe you do a fellowship, and then you would open your own practice. You might have a partner or two, but you would settle down in a community. You would develop a reputation so that patients would want to come to you. Other doctors would want to refer to you, and you would stay there forever. You might eventually invest in your own building, and that would be your community, and you would control how you wanted to work, who you hired as staff, which is very, very important. But all that changed. All of a sudden, doctors are now more often employees than they are employers. And if you're an employee, that's a whole other thing, right? Number one, you don't have the same loyalty as a self-employed physician, you have your own practice. You're not going to pick up and move to Alaska because it's interesting. You have your practice, you have your building, you have your staff, you have your patients. But if you're an employee and you're working for some administrator who, the left index finger from the right pinky, and you're not being treated with respect, you give your 90 days notice and it's off to Alaska. So all of a sudden, physicians became much more mobile. And then the other thing is a lot of these traditional employment jobs like Kaiser or many of the big hospitals now, and academics. I'm an academic physician. I'm currently employed. Physicians have very little control over what happens. Not hiring their own staff, not dictating their own hours. I mean, we just got a new app I have to use, to put in when I want vacation time. It's like it used to be. You told the secretary, hey, I'm going to take 2 weeks off. Now it's got to go through a computer and a giant system. That does not sit well with a lot of physicians. And so what's happened is that younger physicians see locums not as a stopgap or a temporary position, but as possibly a career. In other words, why get locked in to a employment job, which, although it does have benefits, you're not accruing equity in that job. You're a cog. And with all the training that physicians do, most of them don't really want to grow up and be cogs. That's just the way it is. So caveats. Number one, as somebody who goes from place to place to new areas, you have to have some people skills. And if you don't have them, you have to learn them. Frankly, I didn't have a lot of people skills when I was younger. That did not come naturally to me. But I learned, the 3 A's. You have to be nice, affable, have to be available. You got to show up. And then, of course, you have to be able. You have to have ability. So number one, you have to be somebody who's flexible, like I mentioned earlier. You can be nice to everybody, but you have to be able. So you have to be very confident in your skills. So some residents, when they graduate, they're ready to take on the world, but some are not. They're used to being in a supervised setting. They've always have an attending or a senior resident or a fellow they can ask a question to. May not be ready, to be the only neurologist, for example, in Salt Lake City. In this particular hospital. You might not be ready for that. So you have to be very confident of your skills. You have to be willing to be nice. And then you also have to learn, it's not very hard, but nobody ever taught you, you have to learn to run your own business because you are now an employee, right? You're working locum tenens and you're getting a check, but you are also the employer. You are self-employed. And as the employer, you have to decide what benefits you're going to give to the employee, and you have to pay quarterly taxes, and you have to figure out how to save money in a 401k. You have to get your own health insurance, which is not an easy task. You have to plan your schedule so you don't run out of money. There's a lot of things you have to do, which I emphasize, if you made it through medical school, it's something you can do. It's not that hard. But the reason it's hard is because nobody ever showed you. I kind of learned it all on my own. And I have a lot in my book, The Locum Life, about the things that you need to do to keep track of your CME credits, your medical licenses. There is some overhead, but none of it's really very difficult if you've already have an MD degree. You just have to realize that it's another world, business, and you have to learn it.
Excellent. Well, thank you for explaining that. You're planning your financial career, your financial pathway. You're also planning your financial career, and you're an employee, not an employer. So there's a lot of pros and cons about it, and you got to evaluate. Dr. Wilner, give us, our audience, your final thoughts, any message that you would like to convey to them, about the epilepsy part, that's something you're very passionate about, but also something to the locum tenens physicians who are watching as well.
All right, one more caveat that I did not mention, that if it's your dream to be an academic physician, like I'm in academics now, locums is not the way to go. I'm very lucky in that I was able to integrate academics during my career. But if you want to be chief of neurology at Mass General, locums is not what you want to do. So if academics is your world, you could do it for a year or here and there, but it's not. Academics has its own path, and you need to follow that path. Now, epilepsy. When I started taking care of people with epilepsy way back in the 80s, there was a really big problem with stigma. There were even families that would not, and this is also more true in other parts of the world, but there were families that would not, admit that their child, for example, had epilepsy. Um, that is much less of a problem now. So I would encourage people who do have seizures to see their doctor and get it treated. We have very, very effective treatments now, and there's no reason to be having seizures, which are dangerous. People fall down the steps, they drown, they break bones because of these seizures. There's a lot of bad things to happen to people with uncontrolled seizures. And there are very, very good treatments that are available. And your primary care doctor, if he can't fix it, can refer you to a neurologist, pediatric neurologist, or adult neurologist, and get it sorted out. There are also epilepsy centers, what we call comprehensive epilepsy centers, which were a new thing way back in the 60s, which now it's probably 100 of them, in every major city, where there are very experienced neurologists, psychologists, neurosurgeons, social workers, people who know how to take care of people with epilepsy. So I think that's great news, and people should not hesitate to get help. Locum Tenens, I think it's a great opportunity for new residents and fellows who are entering the workplace to experiment, to take a job in a clinic, take a job as a hospitalist, try out Alaska, if that's always been their dream, Southern California. It's one of the things I did. I wanted to go to Southern California, a big city, small city. There's often a scenario with graduating residents where they have a significant other who might be a year behind. So before they move together, there's a year to kind of kill. So that's a great time to do locums, also make some extra money, pay off student loans. Mid-career physicians, thinking about a transition. It's a great way to, one physician I interviewed on my podcast, The Art of Medicine, he is now an incredibly successful thriller writer. He's in his 40s. He's a vascular surgeon. And when he left the military, he tried private practice, didn't work for him. He said, I want to be a writer. He'd always been a writer, but he wanted to do it full time. He worked locums for 2 years while he was building up his library of, thriller novels until they started selling in enough quantity that he could work full time as a writer. So it's a great way to transition to another career. And then a lot of people my age who don't want to stop working will do locums because they just want to work a few months a year, but they're not ready to stop being physicians. Being a doctor, it's a great privilege, and it's also a really special way to help people. And a lot of doctors don't want to give that up. They work their whole lives to get good at it. They don't want to stop. And so I call it the pre-retirement phase is a wonderful time because you have your skills. And if you want to spend winters in Florida, you can do some locums down there, spend time with the grandchildren, or you want to travel half the year and still have an income so you're not draining your retirement savings. You can still support yourself and stay engaged. So anyone who's interested, I would encourage you to read the book. It's not just self-interest here. I think I wrote it for people who want to learn about locums. And one of the compliments I've gotten is there are staffing agencies that help you find these positions. Talked to several staffing agencies that have told me that they have bought my book to give to all of their agents so that the agents who are not physicians will understand where the doctors are coming from and also learn about locum tenens.
Excellent. Dr. Andrew Wilner, thank you for being with us today and sharing your remarkable journey through medicine, through writing, and your brilliant insight into neurology, physician's life, and the power or importance of locum tenens. Continue to guide and inspire so many. Thank you for being with us.
Dr. Khan, it's been a real pleasure. Thank you.
What a remarkable journey we've just experienced together. The path to health isn't always straight, but it's always worth the effort. I hope today's conversation inspired you to take the next step in your wellness journey, armed with new knowledge and a fresh perspective. If today's episode left you inspired, share it with people, someone who need to hear this. Give us a thumbs up and your opinion. Keep exploring, keep evolving, and we'll see you in the next episode of KhanKlinics.